Hello, welcome back to the channel. Today we'll discuss an interesting MCQ. He begs it. Surprised? Keep watching. Here is our MCQ. A 32-year-old male asthmatic is admitted to the emergency department with a 2-day history of increasing wheeze and shortness of breath. His heart rate is 120 beats per minute, blood pressure is 120/60, respiratory rate is 28 breaths per minute with saturation of 92 on room air. He has a widespread expiratory wheeze refractory to his normal inhalers. We asked about what is the most appropriate next step in his management. Option A, intubation and ventilation. B, intravenous magnesium 2 grams. C, urgent chest x-ray. D, back-to-back bronchodilator nebulizer therapy. E, intravenous hydrocortisone. Now pause the video for a few seconds and think of your own answer. Try to work out it before I give you the answer. Okay, now we are much familiar with my MCQ pattern. So as the first step, we'll identify the main keywords here. What are the main keywords here? Here I have highlighted the main keywords. It's a 32-year-old male. He admitted with 2-day history of increasing wheeze and shortness of breath. Heart rate is 120, blood pressure is 120/60, which is normal. Respiratory rate is 28, which is quite increased, and saturation is 92. Widespread expiratory wheeze refractory to his normal inhalers. So from the last sentence we are given a hint that he is not responding to his normal inhalers. So we asked about what is the most appropriate next step in his management. In MCQ like this, first we should distinguish this condition from other causes of acute breathlessness. There's a question arises whether it's a true case scenario of acute exacerbation of asthma or any other condition. So what are the other causes of shortness of breath you know? Either it can be a case scenario of foreign body inhalation. This is X-ray of a foreign body inhalation. This is in a child. Foreign body, most likely button battery, has ingested and aspirated. So it goes and stuck in the bifurcation of trachea most likely. A condition like this can cause acute breathlessness. And also conditions like allergic reactions, anaphylaxis, and also pneumothorax can cause acute breathlessness in a patient. Some other causes are pulmonary hypertension, acute exacerbation of COPD, bronchiectasis, lung cancer, cardiac failure, and many more causes out there. So we are given a hint that this is a known patient with asthma and a known user with his inhalers, and it's a 2-day history of shortness of breath and not just a sudden one. So all of these hints pushes us towards a diagnosis that this is a true case of acute exacerbation of asthma. After confirming it's a asthmatic case scenario, first we should assess and record peak expiratory flow rate, symptoms and response to self-treatment, heart and respiratory rates, oxygen saturation by pulse oximetry. These findings are useful to differentiate severity of attack. And if it's a moderate exacerbation of asthma, usually peak expiratory flow rate is more than 50% to 75% best or predicted. Oxygen saturation is usually more than or equal to 90%. Speech is normal, that the patient can complete a one sentence. Respiration is less than 25 breaths per minute and pulse rate is less than 110 beats per minute. In acute severe asthma, any one of following like peak expiratory flow rate between 33 to 50%, saturation is more than or equal to 92% and can't complete a sentence. Respiratory rate is more than or equal to 25 and pulse rate is more than or equal to 110, like in our case scenario. And if it's life-threatening asthma, peak expiratory flow rate is less than 33, saturation is less than 92, there is a silent chest, cyanosis or poor respiratory effort, there is usually arrhythmia or hypertension, exhaustion and altered consciousness are other features in life-threatening asthma. So here I am not going to describe you further about these 3 conditions. You can read them leisurely, and I am focusing on our condition. So according to our case scenario, it's a condition of acute severe asthma. So in a patient with acute severe asthma, like in our patient, first supplementary oxygen should be given to all hypoxemic patients with severe acute asthma to maintain a saturation between 94 to 98%. And please do not delay this if pulse oximetry is unavailable. And keep in mind that first line treatment for acute asthma is a high dose inhaled short-acting beta-2 agonists such as salbutamol. This is a very important point and it's the answer to our question also. And also keep in mind that oxygen-driven nebulizer is recommended if available. And if the response to an initial dose of nebulized short-acting beta-2 agonist is poor, you should consider continuous nebulization or back-to-back nebulization. And keep in mind to use an appropriate nebulizer. And IV beta-2 agonists are reserved for those patients in whom inhaled therapy cannot be used reliably. In all cases of acute asthma, patients should be prescribed an adequate dose of oral prednisolone. Parenteral hydrocortisone or intramuscular methylprednisolone are alternatives in patients who are unable to take oral prednisolone. There is some evidence that magnesium sulfate has a bronchodilator effects. A single intravenous dose of magnesium sulfate may be considered in patients with severe acute asthma, that is peak flow rate less than 50%, and who have not had a good initial response to inhaled bronchodilator therapy, but it's unlicensed use. In an acute asthma attack, intravenous aminophylline is not likely to produce any additional bronchodilation compared to standard therapy. That means with inhaled bronchodilator. However, in some patients with near fatal or life-threatening acute asthma with poor response to initial therapy, intravenous aminophylline may provide some benefit. Magnesium sulfate by IV infusion or aminophylline should only be used after consultation with senior medical staff. Keep these points as well. So these are some additional points. And back to our MCQ. So we are told that heart rate is 120 beats per minute and respiratory rate is 28, saturation of 92. So these all features leads us to a diagnosis of that this is a case of acute severe asthma. So the most appropriate next step in his management is back-to-back bronchodilator nebulizer therapy. Intubation and ventilation is not indicated as the first step, so it's wrong. And intravenous magnesium is not the next step. Urgent chest X-ray, yes, should be done, but not the most suitable next step. Intravenous hydrocortisone, no, it's not the next step. So the answer is D, back-to-back bronchodilator nebulizer therapy. So this is your take-home message. First, in a case scenario like this, differentiate acute exacerbation with other conditions like the conditions we discussed, and inhaled bronchodilator therapy is the first line, and steroids may follow and can be either intravenous or orally administered. IV magnesium should be given to patients with acute severe asthma not responding to initial therapy or with life-threatening features, and we can prescribe antibiotics if there are features of pneumonia. A chest X-ray will be required urgently to exclude other causes of shortness of breath, but keep in mind that this should not delay the administration of nebulized bronchodilators. So I hope you understood this MCQ, and please read around the topic and read your guidelines. If you use NICE guidelines, you can read them, or any other guidelines such as by British Thoracic Society. So please don't forget to subscribe my YouTube channel and hit the bell icon so you won't miss a single video from me. Let's meet from another important MCQ like this.